All right, so thanks for joining us, everyone. We're going to be talking about wrist injuries in athletes. We're going to focus on TFCC injuries today. So we'll go into a little bit of anatomy and what it's used for, why we have it, how do we treat different types of injuries, and then we'll get into really some of the management with our articles today as well. So when we look at the TFCC, so it's this fibrocartilaginous complex and also this ligamentous complex. So you have your disc with, you have your disc in the middle and your meniscus homologue, and then you have all these ligaments around it. So you have your dorsal and volar radioulnar ligament, which provides some stability. You have its origin coming from the ulnar side of the radius, going all the way to the ulnar styloid. And then distally, you have some of the discarpal ligaments, or the ulnar lunate, ulnar triquetral ligament that anchor it to the other side. And so if you kind of think about it when you explain it to patients, it's almost like a trampoline, the way everything is suspended within that TFCC. Its function is to transmit load with any sort of ulnar deviation. When a normal variance is within the patient, you have about 60 to 80% of the load transmitted to the radius and 20 to 40% transmitted through the ulna. If you take out that TFCC, 90% is transmitted through the radius. So it also destabilizes that radioulnar joint. So that's what those dorsal and volar radial ligaments do. They tighten and they loosen based on pronation and supination as well. So when you pronate, you create more of this positive ulnar variance, which will put more stress on the ulnar side in that TFCC. And when you supinate, it actually does more of the opposite, negative take off of it. There's also, it functions as an essential pivot point, and it's very important for our rotational movements. There's a couple of different presentations where we can separate it from degenerative traumatic tears. So degenerative tears are often asymptomatic, and you can have point tenderness in the area. This can be seen in the 20-30% of young patients, around 30 asymptomatic. It could also be seen in the older patients, up to about 40% based on some of the literature. Traumatic tears will be ulnar-sided wrist pain after a fall and a pronated hyperextended wrist. This is frequently seen with distal radius fractures, so always make sure to look out for that. But they'll have pain with movements that involve any sort of rotation. So simple things like opening a door will be bothersome, hammering, lifting, and gripping. Physical exam, you have the press test, which is a great test, very easy to do. You can have the patient push up on the chair, and if they have pain right in the ulnar area, that's a positive test for TFCC. If you have ECU tendinopathy, it won't cause pain like it does with the TFCC with this test. You also have your compression test, where you're able to take the hand, grab the fingers and the rest of the hand, and ulnar deviate it and compress an axial load, and this will cause pain for those patients. You can also have them put their hands right underneath the table. It's called a supination test, and try to lift up on the table. One thing you want to look out for with the TFCC injury in an acute setting is instability of the joint, the dorsal radial ulnar joint. And so what you can do here is you could have them neutral, and you kind of shift back and forth, or you press downward and pull upwards while on the ulna, and you look for instability or significant movement, and you could compare that to their normal side. Diagnosis, first you get some x-rays. Again, you want to rule out any sort of fracture. You can look at the ulnar styloid as well. The MRI arthrography has been shown to be the kind of one of the better ways to diagnose it, more than a 3T MRI. And you'll see something like we see on the right, where you'll have leakage of the contrast out the area where the tear is, or over here. Whereas if it was intact, or like you look at the other ligaments like scapholunate here, you don't see any leakage of the the fluid within that area. Arthroscopic visualization remains the gold standard for these tears. There's different classifications for it. If you look at MRI, and these can dictate some of the of how they're treated. There's central perforations as 1A. There's ulnar avulsion, distal avulsion, and a radial avulsion. This is how they're classified in traumatic injuries. And they're slightly different with degenerative, where you're looking for things like chondromalacia, or like kind of chronic ligament perforation or arthritis in the area. So the treatment, you have conservative and you have surgical. We'll go in extensively to the conservative management, and then we have Dr. Lee with us today, which would be great to discuss some of the surgical side as well. Just briefly, what's out there? There's the wrist widget was the least least stable, I guess, of all the different types of joint wrist, the immobilization that you can use. It does take off some axial load. It does take off some pressure, about like 10%. So that's a potential use. You have your short arm removable braces. This is an exos cast on the side, but you can also just have a splint. And then you have your above the elbow orthoses, such as a Munster orthoses. So we'll get into all these with our articles, and we'll start right now with the first one.
All right, can you guys see my slides now?
Looks good.
Okay, perfect. So I'm Babo. I'm one of the sports medicine fellows here at Travis Air Force Base. So today I will be talking about the article, What is the Natural History of the Triangular Fibrocartilage Complex Tear Without DRUJ Instability? So this was published in Clinical Orthopedics and Related Research back in 2018. I have no disclosures. This is not the views of the DoD or the Air Force. So background, as we just talked about, a lot of, there hasn't been a lot of studies that look at the natural course of TFCC tears. Also, there's no consensus on the treatment for TFCC injuries. Conservative management is usually trialed if there's no DRUJ instability, and if they haven't improved with the conservative management, which we'll get into, then we typically send them to surgery after a few months. But really no studies looking at who's best suited for surgery and at what time point, and no studies looking at the natural history of the disease. So the purpose of this study was to determine that natural course of TFCC tears without DRUJ instability. And then they also wanted to look at factors that might be associated with poor prognosis. So in this study, it was a retrospective cohort study. It was a single tertiary referral center, and they looked at data from January 2014 to December 2016 through an EMR search, and they looked at ulnar-sided wrist pain. Here's just the quick PICO, and I'll go into it a little bit deeper, but population was 18-year-olds with diagnosis of TFCC tear. Their intervention was immobilization with wrist splinting for 4 to 12 weeks, and they compared symptoms from their timeline to baseline. And their outcomes were their VAS and PRWE scores at these time points, and then their secondary outcomes were risk factors for poor prognosis. So to dive into the methods, inclusion, 18-year-olds or older, they had to be diagnosed with the TFCC tear. So they had to have all these findings on exam, and then also MRI and CT evidence of tear. And then they included traumatic and degenerative changes. And exclusion was indication for surgery. So this was if symptoms were greater than 3 months, if there was persistent severe pain for more than 3 months with adequate non-surgical treatment, and then they were offered surgery at the initial evaluation. Less than 18-year-olds, other causes of ulnar wrist pain, wrist fracture deformities, inflammatory or degenerative arthritis, neuromuscular disorders, or if they were lost to follow-up. And that was if they didn't have more than 6 months between initial visit and their follow-up. So this kind of just summarizes the exclusion and inclusion criteria, but at the end they found 92 that were eligible. However, 20 were excluded because 19 were lost to follow-up and 1 had history of wrist surgery, so their total was 72. This was their demographics, so 40, a little less than half were male, and then you can see the rest of the demographics. They did compare the people that were eligible but included and excluded, and they all, it seemed to be pretty similar. There was no drastic changes between them. So their methods, they used non-surgical management, which was immobilization for 4 to 12 weeks, and they determined how long people were immobilized depending on pain level elicited by provocative testing. They did use short arm brace, the removable braces, and they came up to the MCP. They thought that patients would be more compliant with this, and they were really only worried about ulnar deviation rather than supination pronation, and allowed patients to still have pain relief without interfering with home activities or work activities. And so they looked at the natural course over this time frame. So their outcomes, primary was the visual analog score. So I'll go over that, the PRWE, and they measured these at the initial visit, 4 weeks, 8 weeks, 12 weeks, and then the last visit was 6 months later. Then they looked at different risk factors that could lead to a poor prognosis. So these were the risk factors they were interested in. So here's the VAS, just rate your scale, your pain from 0 to 10, 10 being the worst pain. And then the patient-related risk evaluation. This is a validated 15-question pain and function questionnaire. It scores 0 to 100. Higher is worse pain, lower is less pain. And they use an MCID of a 14-point change to determine clinical significance. If they had 13 points or less, then it wasn't clinically significant. And then complete recovery was less than 20 points altogether then. They use ANOVA with post hoc Bonferroni correction, and then Cox regression for the complete recovery. So this was their results. On average, they had a 2.9 point change in VAS from the initial to final. There was no statistical significance at any of the other points of 4, 8, and 12 weeks, but they did find statistical significance between the initial and final results. The PRWE score, it changed on average 26 points from the initial to the final evaluation. Again, the points in between did not have statistical significance. 45 out of the 72 participants had more than a 14-point change, so clinically significant as well. 24 of them had no change, and then 3 of them had worse pain. This was the incidence of complete recovery, so a PRWE less than 20. You can see in the beginning there was a rapid increase, and then it starts to plateau. And they found 32 patients had a score of less than 20 on the PRWE, and that usually occurred at week 34. That was the average. And then at 6 months, the incidence of complete recovery was 30%, and at 12 months, it was 50%, so slightly better. These were the risk factors for poor outcomes. So they looked at hazard ratio, and if you look through them all, there's none of them were statistically significant for causing poor outcomes. I think the most surprising in this study was that hand dominance and ulnar plus variance were not associated with worse outcomes. So in the discussion, they talked about at 1 year, you have 50% of patients still having pain with conservative treatment. Ulnar variance is not associated with poor outcomes, and then there is no difference in outcomes between trauma or degenerative TFCC injury. There were quite a bit of limitations in this study. Just to start, the retrospective nature of the study doesn't allow us to make any causation. It was just associations between them. The single center, it was a tertiary referral center, so this gives selection bias and likely influence surgical decisions. They did try to adhere to the surgical indications for all patients, but it still offers some bias. And then they thought that maybe the finding of TFCC tears on imaging might have been a incidental finding when doing an MRI or CT. Although they did use all the diagnostic criteria we talked about in the beginning to kind of decrease this risk. And then they had 22% of patients lost to follow-up, which is kind of a lot of patients. which offers some transfer bias. So in conclusion, they said non-surgical treatment is moderately successful for TFCC tears without DRUJ instability. And they found that most of these successes occurred before 6 months. And after that, not really many people had spontaneous recovery. So therefore, they thought that a 6 month trial of non-surgical treatment is a reasonable approach. And then at that point, if they're not doing better, then sending them off to surgery. And then no factors were associated with persistent pain or functional disability after non-surgical treatments. This study does lead us to future studies that we can look into. So identifying risk factors for poor prognosis. This can help avoid unnecessary delay in surgical referral. And then just having a better diagnostic criteria for symptomatic TFCC tears could be beneficial. So in the end, is this study practice changing? And in my opinion, I did not think so, just because of the retrospective nature of it. And also at this point, we do kind of do a 3-month conservative trial, but I think at that point, at least a referral consultation with orthopedics would be beneficial for the patient. There really wasn't much improvement at 6 months. Again, they found 30% had an incidence of complete recovery. Any questions for me?
Thanks, Dr. Babo. That was a good presentation. Appreciate it. I would agree with you that I don't think it's as practice changing. I think the 30% number seems pretty low, and as well as the 50% number. And I guess my question is, if you are doing it conservatively for about 6 months, and that 30% is getting better, what do you counsel your patients? Who do you counsel to see who that other 20% is? Or do you think about, surgery at that point?
So I think that's where finding out risk factors that can lead to poor outcomes would be more beneficial. This study didn't find anything, but I think certainly patients with worsening pain might be somebody that you send immediately. And then there's still a fair amount of people who don't want surgery, and so trialing another 2 to 3 months might not be unreasonable either, based on this.
Makes sense. And they included degenerative and acute tears in this, which I thought was also interesting. They didn't find a difference between the two, even with there was a small sample size. So I just wonder, how that would have changed. And I think our next paper, we'll get into that a bit. But just for Dr. Lee, how many patients do you see responding to these conservative management? How many are able to respond to a steroid injection, or what are some of your thoughts on it?
Yeah, so I'm actually pretty conservative about TFCC injuries because I do believe they get better, but you have to be patient. In terms of natural history studies, that's actually what patients care about more than anything, is what happens if you do nothing. This study, like you mentioned, is retrospective, high dropout. I wouldn't say that's numbers cold, given the fact that it's based on 70 patients, but it does show that with time, even if it's 50%, you could use those numbers and counsel patients and say there is some evidence that maybe somewhere between 30 to 50% of patients without doing anything may get better by 1 year. But when we see them as surgical consults, they've already gone through 6 months, a year or whatnot. And so they, depending on their personality, a lot of patients don't want to wait. They want something more immediate. Being in pain for another 6 months is not ideal for them. And so for us, we're more skewed towards doing surgery. In my hands, if they failed non-operative like casting or so forth, the next thing I usually offer is corticosteroids. And I don't really know if there's great data out there for corticosteroids and what happens. Can I keep injecting them for a year? Will they get better? You know, or they'll like, is there data on? I saw something about like a clinical trial on PRP. Maybe PRP may work for this. But when we see in our practice, in our surgical practices, a lot of times they're 3 to 6 months into their treatment, and I would say probably like half of them I like to proceed with surgery.
It's good to know. And so we'll transition to the next article, which will talk more about traumatic tears, and we'll see if that gives us any different perspective.
Cool. All right, so let me get everything pulled up. So I'm Nelson Shreve. I'm one of the primary care sports medicine fellows here at Travis Air Force Base as well. Today I'll be talking about this paper out of Bone and Joint Journal from 2021, Predictors for Poor Outcome for Conservatively Treated Traumatic TSCC Tears. And this was a retrospective cohort study. Again, like Dr. Babo, these views are my own. They do not reflect views of the DoD or the US Air Force, and I do not, unfortunately, have financial disclosures. And then this is a little bit more of the full citation to the original paper here. So objectives, going to go over the study design, the statistical analysis of the paper, cover the results and the conclusions, kind of the discussion of the story, and then go over the limitations and kind of idea for future research here. So purpose, the primary aim of the study for the authors themselves was really mostly to investigate the use of short versus long arm casting in the use for conservative care for these traumatic TSCC injuries. And then the other secondary goal of the whole paper was to try to identify factors that portend a poor outcome from there. Looking at the study design, the methodology, this was a retrospective cohort study. So strength of evidence is like the 3 there. And then this was done doing a chart review of all patients presenting to a tertiary center in Beijing and seen by the hand surgery team there. They had a specific kind of like classification that they were like a score of 2 to 4 and based on kind of experience and practice background from there. And these data points were taken from January 2015 and ended in January of 2019. So going on to inclusion and exclusion criteria. So they looked at the inclusion for the diagnosis was based off 2 criteria, and they had to meet both of these. So they had to be clinically positive for trauma, presence of ulnar sided wrist pain, pain with supination, positive provocative testing. And then they would also do a piano key testing, again, testing for like the drudge injury or anything like that. And then radiographic evidence. This was done not with an MR arthrogram, but from what I could read, but from a 3T MR of the wrist itself, no arthrogram. For exclusion criteria, if the imaging was not done within 3 months of the injury, they were considered excluded there. If there was a central perforation of the TSCC, they were also only in isolation, then they were also excluded there. And then if they didn't complete 3 months of conservative management as well, that was exclusionary. And similar to Dr. Babo's paper, they really try to get rid of as much confounding other concomitant pathologies such as osteoarthritis of the drudge, if they had any ECU, tendinopathy or subluxation, and then any other kind of inflammatory or degenerative arthritis of the wrist that could complicate things, or in any past history of malunion in the wrist there. This is their table 1 from the study. So they identified 148 patients and 149 wrists. Interestingly, there was one patient that ended up being in the study twice because they had a 1 traumatic TSCC injury on one side, went through the appropriate conservative therapy, and then had a traumatic injury to the other wrist. So that's why the numbers are kind of interesting from the study. But so 22 of them were excluded just because they didn't get the MRI in time. And then a few others, like with acute drudge dislocation, went immediately to surgery, and then with other confounding factors, they can see with a 9 excluded there. And then several people lost to follow-up, similar to Dr. Babo's study as well, that she presented. And then one converted to surgery due to symptoms earlier in the treatment. So in total, 89 risks were examined for this study. So outcome measures, so two of these will overlap the previous study, but the visual analog score, the patient-related risk evaluation, which is scored from 0 to 100, with the higher numbers pertaining to a worse pain scores, the DASH, or the disabilities of arm, shoulder, and hand score, again, higher numbers equals more pain, and like actually it's more of a function kind of testing. And then the modified Mayo risk scores, which was used primarily to determine if patients had a good prognosis, which corresponded to a score of 80 or higher. This is the only test where a higher score is better. So if they had an 80 or higher, they're considered a good outcome, and less than 80 was considered a poor outcome. So here's the kind of the simple kind of overview of most of these kinds of scoring forms. The modified Mayo up there in the top left, and the top right, the PRWS, and then the bottom right is the DASH. The DASH one is a much longer form, and it would have taken multiple slides, so I only put in the one there. So looking at statistical analysis, they did some different tests. The main ones that were the most important to actually what they showed as far as in their final outcomes is the univariate analysis doing the Fisher's test, and then the multivariate analysis using stepwise regression models. So going on to the results from there, the univariate results. So they're basically just breaking down into what risk factors they had kind of predicted it might be important enough to pretend to a poor prognosis. So they looked at sex, similar kind of dominance, hand, if that was pretending to the injury, if they were manual labor or not, the level of trauma of the injury. So if they fell from like 2 meters or more, then that was considered a higher level injury or higher level of energy for the injury. And then presentation, if they were like delayed showing up, and then which kind of immobilization they use. Again, that was the primary aim of the study, was to determine if that was important or not. And then the kind of TFCC tear, looking at the drudge, if that was, if there's any instability found on the MRI there or on exam, and then the ulnar variance. And as you can see here, there's only 3 results that popped out as statistically significant. These were the mobilization with a relative risk of nearly 3, looking at, and the long arm casting seemed to give better predictive good outcomes than the short arm. The kind of TFCC tear, if there was a complete foveal avulsion, that portended to a worse outcome, and then the drudge alignment. So if there was any subluxation, that typically showed worser outcomes there as well. Interestingly, all this talk that we normally do about like ulnar variance and things like that, that didn't show any relation there, crossing over 1 in our relative risk. And then also the delayed presentation, even for a traumatic injury, didn't pretend to poor outcomes. So then they ran through the multivariate. Here, this is what was reported in the paper, and we'll kind of get to that, I guess, in a little bit later. But when they tried to statistically take out as much confounding things as they could and not doing the univariate study, they actually only got down to 2 variables that they found to be statistically significant. Again, the short arm immobilization seemed to be one of the pieces that can make for a worse outcome, odds ratio of nearly 9 compared to the 3 in the univariate. And then the drudge stability question, again, came through in the data. But as you can see, the third point of how much of the TFCC was actually torn, as seen on the MRI, that actually fell away when they did the multivariate analysis. So discussion, essentially, that's the biggest part of this. Their primary aim of looking back over retrospectively as far as what was the most affected or biggest kind of factor, the short arm casting seemed to again and again be the biggest kind of eye-popping statistic that they pulled away from this analysis. That the drudge, interestingly, they even 5 out of 8 of the people that were treated. So there were 8 people with the drudge subluxation in the long arm casting groups when they went back through that, and 5 of those 8 actually ended up still having a good outcome with the long arm casting. So it does seem like the long arm casting was one of the bigger factors overall. And then, yeah, like we talked about earlier, the complete foveal avulsion kind of fell away with the multivariate analysis. So limitations, this was a single center study. So there's obviously concern for selection bias. It's not a very common condition, and there's a very high rate of dropout, similar to Dr. Babo's study. I believe hers was 22% or so. Similar kind of percentage of dropout rates. They tried to address this a little bit in the paper, and they argued that the higher dropouts probably portended to better outcomes. I don't think that's probably the fairest way to treat that. It's normally not how we treat intention to treat kind of outcomes and things like that in RCTs, but going on from there. And then there's a lot of inter observer variability. One, reading with the MRIs, there's 3 people that had to basically agree, with one being the final arbitrator if necessary. And then also with the drudge stability question as well, is difficult looking between observers, making that call off the piano key or the allotment testing, and then lack of randomization, obviously, given that's retrospective, that's classically skewed towards bias. So future research, working towards more of a prospective cohort study, or doing more of a controlled, random controlled trial, specifically looking at the long arm versus short arm casting. Those numbers were pretty grabbing for the attention. So I think looking into that more diligently would be worthwhile. And then expansion into looking more at degenerative tear population. That is typically the population I see more often in my clinic, since I'm primary care sports medicine. But it's just something to consider for the future. And I think my next slide is opening up the floor.
Thanks, Dr. Shreve. Yeah, I thought this study was interesting. Clearly, they're advocating for the use of and based on the data, they're advocating for the use of a long arm above the elbow type splinter cast. I agree with you, where I see mostly degenerative tears in my practice, and I find that something like that, where the compliance could be lower versus just using like short arm splint or even the wrist widget. Are you guys using these long arm splints in your practice at all?
I have, so to this point in like my fellowship here, I haven't had any traumatic TFCC tears come in, so we haven't really done any of that. We've mostly done the short arm just because of the compliance question. I mean, it's tough. I think the most recent TFCC tear patient that I've had, we tried doing steroids, but they're unwilling to go forward with any kind of surgical options at this point in time. So hands are a little bit tied behind my back as well. But yeah, I mean, I understand that the data is that much better, and I get the biomechanical reasons why long arm casting may be the better option, but that patient compliance question, if you can't get them to do it, it's not a very good medicine, unfortunately.
Okay. Does anybody else have thoughts from their practice?
Yeah, I think I think it's a great review. Thank you very much. I really, for those that have traumatic injuries, and if they are a competitive athlete, it's been remarkable. You manage it and you see if they can continue to compete, especially if they're in season. Timing is everything in this. So I think it doesn't even really matter waiting the 3 months, that we would with seeing someone else that's not in a competitive nature. But I've had cases of where we've casted and we've had them continue to play their sport if they're able to. And I would say, some of those come out of that cast and they are doing pretty well. Functionally they're doing well. And those are studies that are hard to do, right? Because you're basically taking this competitive population and you're managing them not for the pathology that you may see, but for their ability to play their sport and how much time you have or don't have. And there may be acute tears that you see that this is the time to do the surgery now so they can recover in time for a bigger event coming up, and so, I think surgeons and team physicians are making decisions with these acute tears based on timing of their function now and function that they have to have in 2 months, 3 months, 6 months. And that is, I think, a study that is difficult to do, to follow those types of traumatic tears.
Yeah.
I would have to say, like, I do see traumatic tears. Well, let me qualify that. I know, like, a lot of patients will have a distal radius fracture, usually have some sort of injury in their carpus or their TFCC. A lot of times when they have like a ulnar styloid injury, and I don't do any immobilization for the TFCC. So basically, I just treat the distal radius, and then that's it. And I tell them it takes about a year to recover, and about 80% of people will get better, 80, 90. And so it's interesting. I mean, maybe I should be long arm casting patients who have TFCC tears and come like 3 months out from injury. But I don't think that for us, that's like standard practice at this point.
I think, so Nico, for any, in the young population that we see an ulnar styloid fracture, for example, I am actually putting them in a long arm cast, and I'm, but the question is, right, it's so non-functional for them. And so I just encourage them to at least stay in a long arm cast until I see healing of that ulnar styloid. At least I see that there's stability, at least in the bone, because who knows what the hell happened, right, to the TFCC. And then once I can get them to tolerate that, maybe I'll go 3 weeks with that, and then I transition to a short arm cast. I don't know what the hell, if that's if that's the good thing to do, but that's what I do.
Are you talking about the isolated ulnar styloid fracture?
Yeah.
Yeah.
I'm talking about isolated or there's an association with like a distal radius fracture, right?
Yeah, it's really interesting how different our practices are, because for us, as long as the DRJ is stable, we say we don't care about the ulnar styloid. People will get non-unions and they'll be fine. And so we just kind of ignore it. So it's really interesting how our practices are so different.
It's always good to hear different perspectives.
But don't you think there's a tad bit of instability in DRUJ with the ulnar styloid being fractured?
Depends on where it is. So if it's like a tip, then no, I usually don't cite that. If it's in the fovea, yeah, then we that's where the deep fibers insert, and so that's when you start thinking instability. If there's any signs of instability, then I will probably go and fix it instead of casting.
Yeah.
Okay.
Just to understand these problems a little better, and thanks to the fellows, great presentations, guys. Are we trying to solve the instability on the ulnar side? Is that really the whole treatment to all this, or is there internal derangement that you've got to actually trim out or repair? Like, what is the goal of the treatment, and why do those people get better? Do we know?
Sorry, who are you asking? Anyone?
Anyone, just for conversation, because I would think, okay, if you have a traumatic injury and the DRUJ is unstable, there's ligamentous damage, okay, putting them in a long arm cast makes sense. For the chronic ones, maybe there's some subtle instability, and maybe there's some, I don't know, fragment. I used to always think of it like a meniscus in there, and that's bothering people. Like, what are we really treating in this problem?
Well, I'm thinking in your scenario with the DRUJ instability, that would be something that doesn't respond well to casting.
Yes.
And
I
you would
think
refer to surgery. Sorry, go ahead, Nico.
No, I think what you just said is key, is that for me, when I look at DRUJ and like TFCC injuries, first thing I have to check is it stable or unstable? If it's unstable, then I think it's something anatomic. You have to go fix. If it's a TFCC that's torn off the fovea, then you go after that. Sometimes it's multi-directional, which which means that it's like unstable in all directions, then you have to do like a reconstruction. If it's stable, you could have two scenarios. One is peripheral. Usually it's the peripheral tears, which can be inflammatory and it could be painful. And those are the ones where maybe casting helps, where you you immobilize it enough so it has a chance to heal, or you do a steroid injection to decrease the inflammation at that level. But then steroid injections do help for peripheral tears or TFCCs. Sometimes patients can have like the deep foveal, the deep fibers. It could be detached, but they could still be stable. And the reason they're stable is because they probably have a very robust dorsal oblique bundle, which is like 40% of people, everyone has a distal interosseous membrane, but then 40% of people have something called a DOB, dorsal oblique bundle, that's well defined. And so even though you have injuries of the deep fibers, you could still be stable. So for me, a lot of times, if I'm going to jump to surgery or do conservative, depends on stability of the DRJ.
Clearly, the stability is key. For time purpose, we'll go on to Dr. Wei, who's actually going to talk about surgery and some of these timing for it in terms of outcomes.
Okay. Do you see the first slide here?
Yep.
Okay. So the article I have is the return to activity after arthroscopically assisted triangular fibrocartilage complex repair. This is a systematic review out of 2022 from the Clinical Journal of Sports Medicine. And I don't have any disclosures. So the purpose of this article was to address or to look at outcomes from arthroscopic TFCC repairs. And reason being is that TFCC injuries are the most common cause of ulnar-sided wrist pain. And we talked about earlier TFCCs with DRUJ injuries have instability, and also probably the reason that they have a low chance of spontaneous recovery. And the authors cite that a third of the patients that have TFCC injuries ultimately pursue surgery. And their other rationale is, despite advances in MRIs and classifications because of that, we still don't have good outcomes on surgical repair outcomes. And so their goal was to review the literature on objective and patient-reported outcomes, functional outcomes after surgical interventions for TFCC injuries. So their article selection, they had over 300 articles that ultimately came down to 15 articles, and their inclusion-exclusion criteria were that arthroscopic surgery for TFCC, so open surgeries were excluded. They had to have at least a year minimum of follow-up. They looked at functional outcomes, including grip strength, range of motion, dash score, pain, and the modified Mayo risk score. And then it had to be an original article and published in English. And you can see that they excluded case reports, reviews, abstracts, and technical notes. Here's a flow chart of how many articles they found and how were they excluding. You can see the 319 or 398 articles were reduced down to 15. And some of the reasons you can see in the second exclusion were that some had no outcome data, others had 4 had associated injuries, and 4 had open repairs. And all of the 15 that they ended up with were graded using them or evaluated using a Miners score, which is a methodological items for non-randomized studies. And it's a surgical score that's a validated instrument to assess quality of non-randomized surgical studies. It's graded 0 through 2, with 0 being not reported, 1 being reported but inadequate, and 2 being reported and adequate. And so ideal score is around 16, and their average was probably about 14 for a lot of their studies. They're 14 to 15, and we can look at those individually in a second. Their population was age 10 to 64, and the average age was 21 to 36. 80% of the patients had arthroscopic repair, with 20% having debridement. And then the most common reasons that people had reported for these injuries were these traumatic. They did have maybe 1 or 2 studies that addressed degenerative, but primarily were traumatic, with this fall and hyperextended wrist with a twist, and were sports injuries. And they followed up 4 to 16 months, and you can see the mean was 11 of 42. So here's the results and some of the scores that they use. So the VAS that Nelson talked about earlier, which was that pain score, they showed that the pre-op mean was 7.5 to 3, and their post-op went 3.4 to 0. So higher is worse, lower is better. Their range of motion and grip strength, those were reported measured with a grip strength dynamometer, and then using degrees measurement for their range of motion, and 90% or better were comparable to the contralateral side or improved. And they did note multiple times throughout that there were varied results. And I think we can see that on the outcomes later. What they had reported was that 3 of the studies had no significant improvement in post-op range of motion. They noted that 2 of those studies, the range of motion was already 90% prior to pre-op and post-op. And then 1 study had no reported pre-op outcome scores. Their patient-reported outcomes were the DASH, and then the mini DASH, which is a shorter version of it, and then the modified Mayo risk score, which Nelson mentioned both of those and showed those earlier. And we can see the 8 of 9 studies had DASH and mini DASH improvements, with 11 studies with the modified Mayo risk score showing 80% good or excellent outcomes. And then here's some more other notable results were that return to activity wise, 10 out of 15 studies reported a positive return to work. 68 out of 100 were reported back to function at work. Out of the athletes, 64% returned back to their sport. And this 3.3% had high level sports return. 84% also of the patients in 10 of the studies showed return to full previous. For complications, they did say that it was very rare, and it was normally this transient dorsal nerve ulnar sensory symptoms were the most common. Let's see. And then here's looking at some of the results. And the reason I brought this one up was that so we could see that how the post-op immobilization went, which is one thing that the article and the authors talk about not being standardized throughout. And then also we can look at the mechanisms of injury here, where we can see which ones were the post-traumatic tears and degeneratives, as well as the age. One other interesting thing was time to repair, and it's quite varied. So you can see as little as 0.25 years up to, here 132 months, sorry, no, 0.25 months to 132 months. And I think that's interesting because Dr. Berrigan has a separate article by Park, which is cited in this review as well, that ultimately showed that essentially between 0 and after 0 to 6, 6 to 12, and 12 or later timeframes for surgical repair for TFCC injuries showed no difference in outcomes. And then on our next, we can see our patient reported outcomes. And you can see here where the return to sport, work in sport were 68, 89, all quite high return to sport. And I think I may have made an error on that 3.3. It's something I want to go back and talk about in a second, because it's different than what our conclusions are going to be from this paper. So, for our discussion and conclusions, most studies indicate a return to work or sport when non-op failed of 80%. And though the data is mixed on the range and grip strength, again, 80% return to pre-functional injury status. And I think that's something that the authors really spoke to a lot, that a high percentage of these 30% of patients that don't get better non-op, again, return back to their function afterwards. And then with regards to their athletes, 90% return back to their full function. And that's where I think I made a typo there with that 3.3%. So, that's a question of, well, maybe our athletes after surgery, are they better patients? Are they younger? Are they more active? And that's something to think about. And then with this range and grip strength varying, this is where earlier talking about how there was different post-operative protocols, makes it challenging to assess all the studies and the outcomes with respect to people returning, or maybe, with a high return, maybe that part is not that important, but in the sense of standardizing it for like a protocol, that hasn't been established yet. And so limitations wise for this study or for this review, that there's no sham surgery. So, none of them were able to went in and, made a sham version of the surgery. They talk about the TFCC being complex with anatomic variations in blood flow. And so does that lead to any challenges in repairs and outcomes? And does that make a difference? And then complex versus degenerative, what we talked about before is that a lot of them were traumatic and not necessarily all degenerative injuries. And then classification based on studies wasn't, in terms of using that Palmer study, that again, or Palmer classification, that grade, that one grade is, or A is traumatic, and that degenerative being that second classification. What do we do in those cases? So, these are what I spoke to earlier is standardized protocols for post-op, something, and this is what the author spoke to as well, that it's something that future studies can look at, as well as, for me, I was thinking about early selection. Can we get that 1/3 of patients earlier? And, my thought on that is I'm not too sure, as we saw like that, from that Park study, as well as this study, that despite when you intervened, it's not about the timing of intervening, but selecting who will do well. And I think there wasn't any difference when I looked at the data in terms of selecting looking at the articles that had earlier intervention as well as their return to work, looked like very similar in that 60 to 80%. And so what questions does anybody have?
Thanks, Dr. Wei. So, based on these 3 studies that we presented today, you have this high level collegiate athlete, lacrosse, falling on outstretched hand, pronation in there, has this ulnar-sided wrist pain. MR arthrography shows the TFCC tear. He's in the middle of his season. What are you, how are you counseling him? What are you thinking about? And, what are some of your steps with this?
Yeah, I think thinking about this, I think with Dr. Lee talking about instability being a significant decision point, I think that would determine, like, I still think I would lean on that towards surgery or non-surgery. And if, 2/3 of the patients are going to improve with non-operative treatment, though it may take some time, I think that if your goal was to avoid surgery, then I would probably recommend not going to surgery. And I think that time frame of when they're going to improve or not improve, like maybe you give them 3 to 6 months, or you track it earlier to see how they're doing, then maybe that can help narrow down that selection to say maybe they will do better with surgery afterwards.
Yeah.
Well, I think one of the key variables that Bill said, you're so formal, Bill, with Dr. Wei, maybe because it's recorded, sorry, but is the fact that he's mid-season, right? So I know you're talking about the studies and what the studies have shown, Ryan, but the key here is activity level, right? And he's a lacrosse athlete, right? So it's really a hand, it's hard to put someone in a cast, unlike like we put a running back football in a cast with a TFCC acute traumatic tear, and they were able to carry the ball and block, do the things they needed to do. But with a lacrosse athlete, their function is different. And that's the one thing about your study, is when they talk about greater than 90% of the athletes go back to their competitive sport. I couldn't see your table because it was too small on my phone, but it really depends on their population that they studied, what type of sport, what type of athlete. A gymnast is very different than a non-dominant basketball player, right? Non-dominant hand of a basketball player. But in this case, you have to look at that scenario as a team physician, is sport and as well as the timing in the season.
Right.
So keeping that in mind, and then knowing the data that you guys just reviewed, how does that change what you do?
The one thing, I hear what you're saying, and I think with that, like greater than 90% returning back to high level sport sounds like a really good choice for this lacrosse player. I think the other thing I don't know that I didn't come across in my article or heard is just like that time to recovery. So whether that's mid-season, Like, will they be back for part of the season, or how long that recovery post-op will take? Does anybody know that timing?
Yeah, so post-op back to contact sports, about 6 months for it. So post-surgery, they usually, at least, some articles suggested about 6 weeks in a long arm cast and like another 2 weeks in a short arm cast. And then they're doing some rehab, some therapy, but the contact sports was on average about 6 months.
Okay. I mean, it certainly sounds like if looking at the data, if a third won't get better, then 90% of those do get better with surgery, that it would be a good recommendation in keeping them at their high level sport.
He is going to want to try to play. I'm just going to tell you that. If you say to him, well, I looked at the studies, it's acute injury, you've got some instability. If you have surgery, you're going to be, going to have a full recovery. And then you look at the timing of the next lacrosse season, for example, or what he has to do. But this is the mid-season, and
Right.
he's going to want to try to play. So this is where the shared decision making comes into play. You share your data, you share the evidence, and then you get his opinion in terms of what he would like to do, knowing the data. Because I don't know, I'm not aware of any data, but of the if he continues to play and makes things worse or creates a synovitis in his wrist, does that affect outcome, surgical outcome, if he waits and continues versus having the surgery right away? I don't think we have data on that. So, I mean, Bill, are you aware of any data about that, or Nick?
Well, the second study did show that even if you wait like 2 to 3 months, you could still do conservative management. So I think that's where I would counsel them, is like, you do symptomatic relief in the middle of the season, maybe put a brace on, or like a wrist widget or something. But at least the second study showed that if you're waiting 2 to 3 months, and it really affects outcomes. And then as Ryan had said, that in the other study that we're looking at, 0 to 6 months, 6 to 12 months, and greater than a year, the timing didn't affect it as much. So I think that's the good news with this type of injury, or at least reassuring, is that these athletes might be able to continue to play and then get something off season, if starting with conservative management, and then if it is surgery.
Yeah, I agree. I would do exactly what both of you said. I would really counsel the athlete on the risk benefits and talk about the outcomes that you mentioned, Ryan. And then also the, data from some of the earlier studies, to Bill's point, that even if you do delay it, there is a chance that you can still recover from a conservative standpoint, but it's going to take a while, which may overlap with their next season, right? And then talk about the surgical options, especially if there's instability, and then what that recovery time looks like. But, I agree with Dr. Chang. The lacrosse athlete is going to want to keep playing as much as possible. So it's really about having that informed discussion with them. That's going to be most important.
Yeah, that's great. I mean, that is such a great conversation, because this is what the return to play is like, right? The decisions. And yeah, my point was, like, there's no adverse outcomes. If you wait to have surgery, that's my whole thing. Since sort of one thing, but if you wait to have surgery and then you have surgery, I don't know of any studies that show that there's adverse outcomes worse if you wait to have surgery too. God, I can't say that, but you know what I'm saying, what I was trying to say. So it's all good news from the perspective of, we can try it. But yeah, in the back of your mind, I've had someone with a Liz Frank tear clearly on exam. That's what he has. He's unstable. He's going to need a screw because of the widening, but he wanted to try to play. He's not going to be able to do it, but you try to let them go, and they have to make that decision sometimes. Yeah, he couldn't play but a few plays, and then he was out. He's like, I can't. There's no way. I'm like, okay. But sometimes they have to demonstrate themselves, right? Anyway.
Cool. Well, thanks, everyone. Thanks, Bill. I know you have clinic, so I'll let you run a clinic. Thanks, Ryan, and thanks for presenting.